Good morning. Welcome to the third in our peer-to-peer webinar series here at ClearPoint TV. We're delighted to have with us today Dr. Chen, who's a professor and Lyle French Chair in Neurosurgery and Department Head at the University of Minnesota Medical Center. Dr. Chen is an internationally recognized brain tumor researcher and surgeon with a dedicated interest in understanding how glioblastomas acquire resistance to radiation and chemotherapy. He's also an NIH R01 funded investigator with research focusing on developing novel diagnostic and therapeutic approaches for brain tumor patients. He's also a leader in the study of DNA repair and gene therapy in brain tumors, and we're delighted to have him here today to speak on emerging applications of ClearPoint in neuro-oncology. Thank you, Dr. Chen.
Well, thank you for this opportunity to share our experiences using the ClearPoint system. Let me go ahead and see if we can share the screen. And can you see my screen right now? Yes, okay. Yes. So then I'm going to go ahead and go to the presentation mode. And by the way, I really like that video. That looks very, very impressive. So this is here's my disclosure slide. I am a consultant for the following companies. And here's the outline of the presentation for today. I would like to introduce you to the relative merits of ClearPoint as a function of the current stereotactic system. I'd like to share with you the workflow that we've developed here at the University of Minnesota. And I'm going to highlight some of the unique applications of ClearPoint in the neuro-oncology space as it pertains to really small lesions, as it pertains to salvage surgeries in patients who have failed a first biopsy, as it pertains to brainstem lesions, and its application in multi-trajectory laser ablation and in drug delivery. So, as all of us know, stereotaxis is a mathematical calculation based on the principle of triangulation. That is, if you know a particular lesion relative to other known geographic locations or geometric locations, you could pinpoint precisely where that lesion is. Now, historically, we've done this using the frame-based or frameless stereotaxis. In the frame-based stereotaxis, the known geographic location or geometric location are those posts. So we could calculate the lesion relative to these posts and to define a spatial location based upon those relationships. In frameless biopsy, we're defining those geometric relations relative to your fiducials, as shown here by, this is the BrainLab system, and certainly there are multiple systems that can be used. And we essentially are defining the surface features relative to these fiducials and then calculating the lesion relative to these spatial orientations. Those were historically what we've used. And for the most part, if you survey the literature, and this is a meta-analysis that my group had done, looking at the entire literature of published results in terms of diagnostic yields and morbidity and mortality, essentially we do pretty well with these standard systems. For frame-based and frameless systems, where our diagnostic yield is somewhere between in the high 80s to 100s, with morbidity and mortality in the low single digits. Now, as best we could tell, the available literature does not suggest there is a difference in terms of the effectiveness of frameless versus frame-based biopsies. Now, the problem is, if you survey the literature and look at all the papers, the average size of the lesion biopsy is more than 3 centimeters. The reality is, if we look at the biopsy diagnostic yield as a function of the lesions, as we approach the smaller lesions, we start to lose those diagnostic yields. Here's an honest study that I did looking at nearly 300 biopsies where we had both the initial biopsy results from the stereotactic needle biopsy and subsequently had a surgical resection. And what we found was that the diagnostic yield is indeed really good for lesions that has a diameter of at least 1 centimeter. We achieved a 95% yield. And in this case, we're doing only frame-based biopsies, okay? All of the, in this case, 246 cases were frame-based biopsies. And this was accumulated over a 3-year period. But as you look at those lesions that are less than a centimeter, the diagnostic yield dropped down to 76%. And here are some of the examples of situations where we either misdiagnosed based on the needle biopsy or didn't achieve diagnosis. You know, this is one example of what initially in a needle biopsy was called a grade 3 endoplastic astrocytoma. And so we went in and resected this tumor. It turned out the actual tumor is a subependymoma, right? So you could see these were the size of the lesions that we're dealing with. And as we look at why it is that we weren't able to achieve accurate diagnosis, it came down to 2 things. One is that in the absence of visualization that we're actually inside the lesion, it is challenging to perform and added biopsies. The second issue is without seeing that whether we've caused hemorrhage or other complications at the biopsy site, it's uncomfortable to take another biopsy and another biopsy and another biopsy. And this is when I realized there's a tremendous value in visualizing the site of the biopsy, not only to confirm that you're in the site, because if you know you're in the site and you didn't cause hemorrhage, it's very easy to take additional biopsies in order to secure a definitive diagnosis. Here's another study published by another group that looked at patients who initially underwent a stereotactic needle biopsy and did not achieve a definitive diagnosis. So this group looked at 21 patients and they looked at what happens upon rebiopsy. And in the rebiopsy, they were able to achieve diagnostic yield of 90%. So in other words, it isn't that there isn't a tissue diagnosis to be made. It is that the initial biopsy was inadequate. And so there are opportunities for improvement in terms of our surgical techniques. Now, why is it that we are running into this misdiagnosis or non-diagnostic tissue? Certainly, we talked about the uncertainty of not knowing if you're in the right site. Another issue is that just by virtue of making the burr hole, this is wonderful work done by Paul Larson, just by making that burr hole and allowing some egression of CSF, there is actually shifts within the brain. And if you don't know what that shift looks like and accommodate it in your trajectory, you could very simply miss a small lesion without realizing that you missed it if you can't visualize where your needle is relative to the lesion. Another issue pertains to the fiducials. This is a studies done by Dr. Wakabayashi's group, where they show that and we all see this in our real practice, that if your fiducial or if the site of your registration is close to your pin site, there's distortion. And if your fiducial is distorted, if your known geometric location is distorted relative to your unknown, of course your unknown will also be shifted, right? And finally, there's the issue of skiving. Again, for all of us who do biopsy, there are always situations where you're trying to do a burr hole in a curved area, and rather than the hole being precisely located at the intended entry site, that the curved surface forces the drill to shift just a little bit. If you're doing a burr hole, it's not unusual for a resident, for example, to have to extend the burr hole a little bit in order to achieve a perfect trajectory. The problem is if you don't realize that this shift occurs, the so-called skiving, one cannot adjust for your trajectory. And what I'm showing you here is a minor deviation on skiving translate into significant distortion of where your end result biopsy is. So by knowing whether skiving occurred and making real-time adjustments, one could better ensure our trajectory in terms of ensuring accuracy of our stereotaxis. Now, ClearPoint stereotaxis, what is it and how does it differ from the traditional stereotaxis, and what are the benefits? The ClearPoint system is an integrated system whereby there is a software algorithm that will take in real-time images based upon a stereotactic MRI compatible frame that is mounted onto the patient's head. Now, the frame that's mounted, as you can see here, has two components. There is a base component, which has 3 fiducials that are filled with MRI visible contrast. And what the principle of the system is based on is that you can localize these 3 fiducials relative to the lesion, just like you could localize the lesion relative to known positions of posts or the superficial skin anatomy. The second component of the system is that there is a tower, as shown here, and the tower has a cannula that's also filled with contrast enhancing material. So this frame has 6 degrees of freedom. There's a translational X and Y as well as the pitch and a roll. So by having this frame mounted onto the patient, we could calculate where the lesion is relative to the 3 fiducials, and then we could direct that cannula to the intended target lesion. And that's essentially the principle of ClearPoint stereotaxis. What are the advantages and the disadvantages of the system? Well, the one major advantage is that one could achieve sub-millimeter accuracy in terms of trajectory and target definition. For me, a major benefit is that I can confirm my trajectory. I know exactly where my biopsy site is. If there's brain shifts related to CSF leak from a burr hole, I know precisely how to account for that, and so that I end up in the lesion. If there is skiving from my burr hole creation, I know exactly how to adjust for that. So that confirmation is very important, and the ability to adjust my trajectory in real time. And these are, again, not terribly crucial if you have a 3-centimeter lesion, but they're eminently important if the lesion is sub-centimeter. Another major advantage is by virtue of the fact that you could shift your XY and you could achieve multiple trajectories from a single mount of a frame. And I'm going to show you some examples of how we utilize that to benefit our patients. We've used this platform for drug delivery and for laser ablation. And one of the key things that I use this for in terms of laser ablation is when you use the ClearPoint frame, you do not need to insert a bolt. And the reason that's important is to date, the bolts that we have are metallic and they create an artifact around the site of placement. And that artifact, if it's next to a superficial lesion, can obstruct your view of your laser ablation. And so for superficial lesions, I would come to ClearPoint in order to avoid that distortion. Now, it's a common misconception is that ClearPoint requires a dedicated intra-operative MRI. This is not the case. When I first started using ClearPoint, we were using a diagnostic MRI rather than a dedicated intra-operative MRI. So the system is compatible to all MRIs. And we talked about bolt-related artifact already. Now, the disadvantage is the frame is an additional cost. And as you see from the workflow, it does require a little bit more time, although not a lot, in terms of aligning your trajectory. But really, the reason you're using the system is so that you have the opportunity to correct your trajectory, and that does consume time. And for those of you who do not have an intraoperative MRI, it does require coordination with diagnostic MRIs and cleaning of the MRIs to prepare for a surgical procedure. And we've published on this. If there's interest on this, we could share with you what that coordination looked like. Now, what is the workflow? Well, the ClearPoint system does not require a preoperative MRI, which many of us do before surgery. It's entirely, the MRI is done during the surgery. And the first step in the procedure is to place the so-called Smartgrid. This is a grid that you see here on the left upper corner. Essentially, these grids are divided into 26 quadrants, and each of which has a single collection of contrast-enhancing material. And the reason for this grid is to identify the precise entry point to the lesion. So for example, after the grid's applied, an MRI is taken, you can see a picture here, and you can see which of those grids correspond to the optimal trajectory that was predefined before the surgery. This grid has two layers. The first layer has those contrast-enhancing material. Once you define the location, you could take that portion of, and you can see this is the bottom portion. From the bottom portion, again, you identify the ideal entry point. And here, what I like to do is actually insert a sharp instrument and make a divot in the bone, such that the instrument could actually stand without support. That indicates I've actually made a small dimple in the bone. Once that dimple is made, there is an instrument where you can find that dimple and mount your frame, which is secured by 3 small screws, so that you're centered precisely at that entry point. After that, after the frame is mounted, then the tower is placed, and then the extensions that will allow you to make adjustments to your trajectory is then placed. And after that, MRI is taken, and the MRI will calculate where your current trajectory is relative to your intended target. And then you would go in and using these various knobs correct for your course so that you can achieve the optimal trajectory. And this cycle is repeated until the ideal trajectory is obtained. Now, for the deep-seated lesions that I'm going to show you in some of the examples, what I actually do is take an extra step to ensure absolute accuracy by inserting a ceramic stylet halfway through so that and recalculate my trajectory after that's inserted. If that trajectory is ideal, I proceed with the procedure. If not, we make further corrections. And you can see this ceramic stylet here. And to me, this is the value of ClearPoint. That is, I know precisely where my target is relative to my trajectory. And if I'm off a little bit, I have the choice of making the correction. Or if the lesion is medial to my lesion, I know what that relationship is, and I could direct my biopsy toward the side of the lesion. Whereas historically, this is a blind procedure. We go in, we do our biopsy, we take 4 quadrants, and we hope that we land it in the right spot. And again, if this is a 3-centimeter lesion, yeah, you're going to end up in the right spot. But for some of the lesions I'm going to show you, a little bit off means not making the diagnosis. All right, so now I'm going to move on and talk about some of what I think are unique applications that ClearPoint clearly offers a distinct advantage. So smaller lesions, we alluded to this earlier. Here's a very interesting case of a 38-year-old woman who presented with diabetes, insipidus, and hypopituitarism. So here are sequential MRIs taken over a year. You can see that initially there is this stalk lesion that progressively enlarged through time. This is a very delicate portion, and the challenge of coming in transsphenoidal is this is behind the pituitary gland in the stalk region. And certainly the option of coming in transsalvian is also a consideration. What we ended up doing ultimately is to use the ClearPoint to biopsy this lesion. And the planning of the biopsy is something that has to be, the surgeon has to invest a lot of time in. If you look at the different cuts of this trajectory, which is a very steep trajectory or very deep trajectory, there are multiple opportunities to intersect vessels or sulcus or or the ventricle. And what I generally like to do in these cases is to make sure that I have at least 2 to 3 millimeters of distance between my planned trajectory and the sulcus or vasculature or anything that I'm concerned about. So after this careful planning, we ended up, again, doing the biopsy, and we, again, inserted, as I described in my in the earlier slides, we've aligned the trajectory, we drilled a hole, everything looks good. We inserted that ceramic stylet halfway through, and lo and behold, we found that we were off. So, you know, for many of us that have done a lot of biopsies, we realize there's technical nuances at every step that could cause these millimeter deviations. And for the most part, without the MRI, we can't make corrections of those, right? I did this procedure skin to skin. Everything that I did was myself. It wasn't a resident. And still, if I had proceeded with the initial trajectory without seeing intraoperatively how far I was off, as shown in B, I would have ended up in a CSF space. But by making additional corrections, we were able to align ourselves perfectly to the intended lesion. Here is a confirmation that I was precisely at the lesion. You can see our biopsy. This is a ceramic stylet now inserted all the way to the lesion. And we were able to secure pathologic specimen. And indeed, this is a case of a Langerhans cells histiocytosis. And the patient underwent appropriate chemotherapy treatment. This is a 2.5-year follow-up. You can see that lesion has essentially disappeared. The patient's DI resolved. The patient's pituitary function are now normal. And so this is a great success from a very, very small surgery. And I should mention, and I will show you some of the slides of the incision. The incision for this surgery is 3 millimeters. I don't close the skin, I dermabond the skin. So a great outcome for a 3 millimeter incision. Here's another case where we're dealing with extremely small lesions. And we have, this is a 59-year-old gentleman with the diagnosis of glioblastoma. The tumor is IDH wild type and MGM2 promoter unmethylated. So this is a very unfavorable glioblastoma. The patient's tumor was initially in the left temporal lobe. That was ablated with a laser ablation because it was deep-seated. Surveillance imaging subsequently showed, and this is about 2 years ago, that there is this very small lesion that I'm pointing to with my arrow. And you can see that lesion has progressed through 3 MRI scans. You can see that, I'm not sure why this is going forward. We could see that on the coronal as well. You can see that lesion enlarging. Even at its largest, it's a very small lesion. You can see it on the axial. So this is a lesion that I would certainly not biopsy using traditional techniques because I frankly won't know if I'm in the lesion. So we used the MRI ClearPoint system, and the goal was to achieve tissue diagnosis. And if we see tumor, we would then ablate at the time of surgery. And so you can see this as a picture taken. You can see the dark line of our stylet. We proved that we were in the precise spot. You can see the contrast around the dark spot here. We were spot on in terms of the biopsy, and I know I'm there. I don't have to guess. We did the biopsy, and indeed, this is tumor. There were abundant tumor in the pathology analysis on both frozen and permanent. Based on the frozen pathology, we ended up doing a lesion. So we ablated that area. We took a very generous portion. The patient remained absolutely the same after surgery. The problem is at the 3-month follow-up, there's yet another lesion that popped up that is equally small. So having gone through the first procedure, we ended up doing exactly the same thing. We used the ClearPoint system to localize this lesion. Again, you can see the dark spot of the ceramic stylet relative to the contrast enhancement, which had diffused because it was administered at the beginning of the procedure. And we were able to achieve a second ablation. Now, in all fairness, because this is in the century strip, the patient did have proprioceptive defects afterward, but he's recovered from that. I would say that 2 years later, the lesion remained well controlled, and the patient, there's no evidence of disease recurrence on MRI. So what we're doing here is really taking an advantage of our ability to biopsy a small region and catch the disease early. In every cancer that we know, early detection and treatment is the key to prolonging survival. We've not been able to do that in glioblastoma because we were not given the opportunity to intervene when the tumor is really, really small like this. And honestly, I think part of that has to do with the comfort of knowing whether or not we're going to get the right biopsy and get to the right spot. So these are, of course, cases where I think ClearPoint offers a unique advantage. I'm going to talk about salvage surgery. And by salvage surgery, I mean someone who had a surgery before and the diagnosis was not made. Let me give you a couple of examples of what I've dealt with. This is a case that we published in Operative Neurosurgery. This is a 71-year-old gentleman who came in with this contrast-enhancing lesion that's highly irregular, curvilinear, and it involves the left temporal horn. Unfortunately, this patient was given steroid, and the patient was taken to the operating room for biopsy 2 days after steroid was given. The biopsy was non-diagnostic. An MRI was done because the tissue, or rather, because the initial diagnosis is non-diagnostic, and what the MRI shows is that lesion, frankly, just melted away. And of course, all of us will be concerned about a lymphoma, except that no oncologist is going to treat this patient without definitive tissue diagnosis, given the toxicity of treatment. So we follow this patient serially, and ultimately the patient developed this contrast-enhancing area in the periventricular region that is 1 to 2 millimeters in the maximal sort of width. Now here you have a choice. You have a choice of waiting until this blows up, which is not appealing from the context, in the context of what I just talked to you about, which is early detection, early treatment has benefits. That's been shown in every cancer that we know of. So the option here is, can we do a biopsy of this lesion? And I would say for all of us, this is a daunting lesion to biopsy. So we used a ClearPoint system, and what I'm showing you here again is we went through the workflow that we talked about. You can see here, we can see that the needle, this is the ceramic stylet. We are ending precisely at the contrast enhancing area. You could see that dark spot in the contrast enhancing area on all 3 views. You can see that we've secured a biopsy, and at the tip of the biopsy, there's something abnormal here. And that abnormality indeed is a lymphoma, and the patient underwent treatment at this point. I've alluded to the incision size. You could see here the incision because we were able to use the Smartgrid and only make a stab incision. The incision literally is 2 to 3 millimeters. And this is 1 week after surgery. It's almost like you just had a paper cut. Here's an example of another salvage surgery. This is actually a 19-year-old gentleman who underwent a biopsy for this lesion, and the patient was referred to me as the last patient was because the tissue was non-diagnostic. And in fact, the MRI taken after the procedure showed that the track of the biopsy ended prematurely and is inferior to this lesion. Now, this is a patient who underwent a suboccipital burr hole for this biopsy. So there's a big incision, and unfortunately, no definitive diagnosis. So knowing, again, this is going to be a challenging biopsy, we use the ClearPoint system. And in this case, the incision here, you can see this is the prior incision for the biopsy, and that's the burr hole from the prior incision. And we mounted the ClearPoint frame directly onto the bone this time. And you can see that this is our trajectory. We were able to ascertain tissues. I'm going to show you what the tissues were. This is the biopsy, rather the ceramic needle that is confirms that we're in the lesion. This is a H3K27 mutated glioma. And as we made a definitive diagnosis, we inserted a laser probe through the same procedure and ablated the area. The patient ended up, the patient ended up benefiting from this. It's the H3K27 tumor is one of the more, if not most aggressive form of glioblastoma. And this patient actually ended up achieving local control of this lesion and survived for about 20 months. Here's another case of what I call intra-operative salvage. This is a patient who had a breast cancer, had radiation treatment, and then this, you can see this is the original tumor. The patient underwent radiation treatment. You can see here the tumor shrunk for about 2.5 years, and then something grew back. Now, why is this a salvage case? Why isn't this a very straightforward case? Well, when we used the ClearPoint system, anticipating that we know some of the lesions that have been radiosurgery treated become very, very fibrous. And I was concerned about the ability to kind of penetrate the tumor capsule. And I need to know where we are before I insert a sharp instrument into the brain. And so you could see, we first tried to do the biopsy, and you could see our initial biopsy site was superficial to the lesion because I hit something firm. I was anticipating a firm capsule. I tried to push this needle through. As you know, the biopsy needle has a blunted end. I just wasn't able to push the needle through this firmness that I was feeling. So I did biopsies, and indeed the biopsies taken here in C were all non-diagnostic. The pathologists keep telling me, we're seeing reactive tissues, and you're probably very close. So we took an MRI, and we see that indeed we're superficial. I tried a few more times to try to penetrate the tumor capsule with the blunt needle, and in fact just couldn't get through. We took many biopsies. We did MRIs to confirm there's no hemorrhage. And ultimately, I had to insert a sharp perforating instrument and push through that capsule. Then we were able to advance our needle into the lesion and secure the biopsy. And indeed, this did prove to be a recurrent breast cancer. So in this situation, I can't imagine myself inserting a sharp instrument blindly into the depth of the brain without seeing precisely where I am. And so this is a form of salvage where if you can't get diagnostic tissue, you can examine where you are, what the relative anatomy is, and design your surgical procedure to accommodate that specific situation. Brainstem lesions. I've evolved so that every brainstem lesion now is essentially performed with the ClearPoint system. Historically, prior to the ClearPoint, I would insist on a frame-based system. Let me show you why it is important to perform these surgeries. Now, there are many people, many practitioners who will say, well, the brainstem, if you think it's a tumor, it's better to just treat it without the biopsy because the morbidity is high in these procedures. And I would push back on that sentiment. If you look at large series, and I'm putting my own series together, I would say my results are very comparable to these published results. The yield and the morbidity are acceptable, right? The yield is in the 80 to 90%, and the morbidity is somewhere on the order of 6 to 10%. So these procedures can be done safely. I would tell you that in my hands, the morbidity is on the order of 3 to 5%, and I don't think that's significantly different from the morbidities reported from superficial lesions. Why is this so important? Why not just assume it's tumor? Well, for one thing, it may not be tumor. And there are publications that described other diagnostic entities that are very confusing, that are difficult to distinguish from tumors. But even if it's tumor, what we've come to realize is that lesions around these areas could have fundamentally different biology and therapeutic response. Let me give you an example. Around the midbrain or the midline, if you were to biopsy these lesions, you could see actually lesions that are either what's called IDH mutated or H3K27. This is one of the series that's published to date, and you could see that some proportion of about 50% of the brainstem lesions that they biopsy were IDH, or rather are H3K27 mutated, and 30% is IDH mutated. Why is that important? Well, there's a cancer cell paper recently published showing that these tumors are completely opposite in terms of their biology. The H3K27 mutated tumors have a very low level of a certain epigenetic marker that forces them into a different biology than the IDH, which has a very high level of this marker. So fundamentally, these two tumors are in the opposing spectrum of biology. And if you don't know that, you can't treat these patients. Most importantly, there are now clinical trials for IDH mutated, for therapeutic agents that target IDH mutated tumor. And so making the diagnosis could mean an opportunity for clinical trial involvement. And ultimately, when we have drugs targeting these distinct tumors, we will need to know. So we'll need to know the status of the tumor. So let me give you two patients that are both done with ClearPoint. You could see that this is, again, confirmation of trajectory, which is extremely comforting for me when I do these procedures. And I want to know I'm biopsying the lesion rather than the brainstem. This is an IDH mutated tumor, very subtle flare abnormality. On spectroscopy, things were suspicious. We observed it, there were enlargements, so we ultimately biopsy this. This is an IDH mutated tumor. Here's another tumor, very subtle midline lesion. We were able to confirm our biopsy. This is an H3K27 lesion. There's no way someone could look at this before the biopsy and tell you what they are and how to treat them. So as we evolve and improve on our therapeutics, there will be more demands on surgeons to obtain tissue diagnosis in order to make sure our patients are treated with the right therapy. Many of you will say, well, right now we do temozolomide radiation for all of them anyway, and that is true. But with an eye toward the future and with an eye toward clinical trial involvement, it is essential that we have a good tool to biopsy these lesions. And I think the ClearPoint is a very good system in that context. Multi-trajectory laser ablations. For the most part, when we perform a laser ablation and commit our trajectory to a single bolt, that's the only trajectory you get. Now, you can indeed make two separate bolts and using two separate laser probes. But I would say that the ClearPoint system offers us another tool where we could mount a single frame and achieve multi-trajectory. Let me give you a couple examples of how this is very helpful. Here's a case that we published in Neurosurgical Focus. Here's a lady with a history of breast cancer and presented with this cystic lesion. Certainly, the consideration is this is breast cancer metastasis. But it turns out what we ended up doing for this patient is we used a ClearPoint system. We first targeted the nodule. You could see the target and the needle going into nodule, and it turned out this is a glioblastoma. So we did the biopsy first because we want to make sure that there's no significant shifts and we could accurately target this lesion. After that biopsy diagnosis, what we ended up doing is we then repositioned our trajectory so that I could place a catheter in the middle of that cyst so that we drained the cyst. You can see the cyst progressively being drained in figures 2, 3, and 4. As the cyst collapses, we then inserted a laser probe. We redirected the laser probe to the center of this new area of enhancement that resulted from the collapse of the cyst, and we ablated it. This is a patient, and this is the follow-up 2.5 years after the treatment. The patient underwent temozolomide radiation. This patient is promoter methylated, so she has a better prognosis. But through a single small procedure with a couple, in this particular case, we did a burr hole to allow for multiple trajectories rather than small stab burr holes. So we did a traditional, 2.5 centimeter burr hole. But through that burr hole, we did 3 different trajectories. And this patient ultimately ended up with an excellent outcome. You can see the multiple trajectories here. The incision is 2.5 centimeters. We achieved this entire procedure through a small burr hole. I think for a lesion in the left thalamus, this is a victory. Here's another patient we treated very recently. This is a patient who had a gliosarcoma that I resected. As many of you know, gliosarcomas are particularly aggressive, and the prognosis is even worse than the traditional glioblastoma. This patient subsequently developed 2 full sides of contrast enhancement that again enlarged on sequential MRI, but they're still both small, and more importantly, they're right next to a resection cavity. So it's very, very easy to miss this in a traditional biopsy method. So we ended up using the ClearPoint, and that we were able to, you can see in 2 separate trajectories through a single mount, target both lesions. We biopsied both lesions, and both indeed showed recurrent gliosarcoma. That was confirmed subsequently on a permanent pathology. We performed ablations after each biopsy. This is the lesion. This is pre-op. You can see that 1, 2. You can see this lesion here. You can see this lesion here. You can see it on both ends. And here's after ablation. I'm sorry, I don't know why this is. This is the you can see the ablated cavity, and this is 6-month post-op. So there's been no evidence of local recurrence after retreated. Now you'll see the ablation cavity is generally bigger than the lesion. And that's my standard practice, which is that I like to, I know that there are microscopic diseases outside of the contrast enhancement. And so I generally create a larger lesion than that which is initially seen, or rather larger ablation cavity than that is usually seen pre-op. So again, an excellent outcome for a very, very aggressive tumor because we were intervening early. We didn't wait until there's diffuse enhancements all around this area before we acted. And finally, drug delivery. There's a slide. Oh, I'm sorry. There was a slide I was supposed to show. I was looking for it. It's later. I have to make sure I want to show that slide. The company specifically requested that. The agent that we delivered is this virus. This is in collaboration with a company called DNA-Trix. The company has delivered a conditionally replicative oncolytic adenovirus that's engineered to selectively infect, replicate, and lyse tumor cells. And beyond killing tumor cells, the virus induces inflammation and immune response to augment anti-tumor immunity. How this virus works is shown here in the right diagram. This is a study that's gone to phase 2. This is the work of Dr. Fred Lang, where he was able to secure samples after virus was delivered, and he's able to show indeed there's T cell infiltrate and microglia proliferation in the region after the administration of the virus, and he was also able to show tumor lysis. This is the results thus far in this phase 2 study. Now, this phase 2 study does involve the delivery of the virus into a deep-seated tumor through a convection catheter. Okay. The outcome here is impressive, and I'm going to show you one of the patients that we treated. We've treated several patients with this virus through the system I'm about to show you. And the system is that you could use the clear frame stereotaxis, and the adapters have been made so that they could accommodate this convection catheter. So effectively, what you can do is use the same system, target area, visualize where you are, insert the catheter. And this is the slide I was supposed to show, that this is a part of a clinical trial. So let me show you some of the outcomes. So here's one of our cases. You could see that the classic step off in a convection design. And this is the smart frame that was mounted. This is sorry, don't know why my computer keep flipping back and forth. You can see this is the pump that was used. We essentially insert that there is a adapter that allow a perfect fit between the catheter and the smart frame. We insert that to the depth and we secure. Here's a patient that was treated. This is a patient with a glioblastoma. This is not an H3K27 mutated tumor. This patient has recurred. We biopsied, and indeed we prove that this is recurrence. And we infused the virus and this trial through the smart catheter. Now, this trial also involved the use of immunocheckpoint therapeutics after treatment. And what you can see here, and this is now well more than 18 months, the tumor melted away. I mean, this patient is still alive today. For all intents and purposes, she seemed cured. And this patient has now been followed for more than two years now. So this is a very impressive result. And you'll probably see this in the publication of this clinical trial. Now, one of the cool things that we can do, because if you were to do this in a diagnostic or MR or a intraoperative MR, is that you could actually take a picture immediately after viral delivery. And what you see is that you could see a region of hypointensity from your infusion. You could see that in these two patients. And in fact, we were able to correlate therapeutic response based upon whether we see this region of viral infusion. So, in summary, I hope I shared with you sort of the relative merits of the ClearPoint stereotactic system relative to the current system. I've shared with you our workflow. Certainly, there can be other workflow developed. I know that other surgeons who use the system have modification of the workflow that I showed you. And I think that there are unique advantages of the system as it pertains to really small lesions. I mean, the fact that we could see where our needle is knowing that we didn't cause harm after our biopsy gives you the confidence of taking more samples in that area. We talked about the utility of this in a salvage surgery, right? The definition of crazy is when something doesn't work, you keep doing it. If you did a first surgery and it doesn't work, you got to use something better. And I think this is that something better. The brainstem lesions, we're all very respectful of the brainstem. And more there will be rationales to secure samples and possibly even infuse therapies into the brainstem. These clinical trials are ongoing for brainstem lesion oncolytic or chemotherapies. For multi-trajectory laser ablations, rather than using 2 bolts and 2 lasers, it's absolutely possible to do a single mount with multiple trajectories. We do this routinely. In cystic lesions, we can indeed drain the cyst, let the things collapse, redefine the lesion, and ablate. In some situations, we could do 3 separate trajectories: a biopsy, a cyst drainage, and then an ablation. And finally, an emergent area that has to be carefully, that requires surgeon participation, and we should all actively participate in, is in drug delivery. And the fact that the system is compatible with a unique, specifically designed convection catheter is a great benefit to the system. With that, I'll stop and see if there are any questions.
Thank you, Dr. Chen. There actually are some questions, and thank you for that wonderful presentation. I think you covered a lot of different topics and uses, both emerging and standard of care for the ClearPoint system. So we do have a question from Sweden. Question is, for biopsy, do you always have assistance from a ClearPoint expert, or can you do some of the procedures alone?
Oh, that's a very good question. I always have someone help me. One of the drawbacks, and that's a very good point I should have listed, is that it does require, for me, even after doing so many procedures, a dedicated person. Now, with the development of this type of Zoom conferences and FaceTime, I suspect that some of the technical aspects may be able to deliver through these type of interactions. But historically, I've always had someone on site.
Great, thank you. The next question, I think, is from the Chicago area. Can you comment on your learning curve using ClearPoint at different institutions and on different setups? You've gone from GE Diagnostic to Philips Diagnostic to IMRIS.
Yeah,
I'm following your career.
Yeah, we actually have data on the learning curve, and the learning curve is roughly about 10 cases. We're putting a manuscript together right now, and honestly, this manuscript's sitting on my desk for a year now. I really should just get that done and submit it. Essentially, we could see a big step sort of function in terms of the time needed for the surgery. The first 10 cases, there are going to be some learning challenges in terms of not just the surgical aspect, but the technical aspect in terms of the interface between magnets and, distortion corrections and things like that. But in both experiences, after about 10 cases, we see that the time drops to about half of the initial time of surgery, and that becomes kind of the norm. And the reality is, for these biopsies and ablations, we're typically able to finish the surgery within a 2.5, 3 hour kind of procedure, and that's not significantly longer than a standard biopsy.
Great. Our next question, great slides. What modifications, if any, do you make to your usual incision/frame mounting process in order to accommodate the ClearPoint frame for very low occipital entry points, especially for brainstem lesions?
Yeah, that's a really, really good point. I show you a case where someone had made a big J-shaped incision, and I mounted the frame directly on the skull. The muscles and fats in the back of the neck is a challenge. The frame, the screw that comes with the frame are not steep enough if you have a very obese patient. And so I would say that if things are really low, one consideration is just to, make that J-shaped incision and mount the frame on the skull. That's one consideration. The other consideration is that I almost routinely use, there are 3 screws that mounts the frame, but there are also 3 spots for what's called a rescue screw. I find that using the rescue screw to be very helpful. And I've actually gone to routinely using all 6 screws. So I think the considerations are, if you have something that you think is going to be less than mobile, or less than, or the depth of the tissue is going to be greater than the depth that you could penetrate, it's worthwhile considering just doing a skull mount. There are other surgical maneuvers I could certainly, I'm happy to review, on a one-to-one basis. For stabilization, but I suspect those are probably not sanctioned by the company.
Okay, thank you. A couple other questions here. How well known is the ClearPoint system in your field of surgery, and do you see this becoming a mainstream tool?
Well, I'm using it fairly routinely for the indication that I'm showing you here. I think that there are more and more awareness of the benefits. It only takes one missed biopsy, right, to understand what the benefit of what I'm showing you. My expectation is that as our tumor patients become more sophisticated, as the demand on tissue diagnosis become more standard of care, that we will be using this type of system where we will be able to visualize where we are. Another thing that I'm not showing you here is more that we're doing is more experimental that we haven't, is that we're starting to do multi-biopsies based on different MRI imaging modalities, because we know the tumors are highly, highly heterogeneous. And the ability to really know where your biopsy is relative to a very small foci of, let's say, methionine imaging or DWI, influences the quality of research. And so there are also going to be increased demands of accuracy from the research side, right? It used to be you do a biopsy, or you take a tumor, someone will profile it. Well, today for research, that's done, and in the past, I mean, the tumor's been profiled to death. What we really need now is knowing particular region of the tumor relative to what the MRI shows, or what the PET shows, or what the CT shows, and really understanding what that variation means from a biological perspective. So I do see more and more demand for accuracy. Now, in all fairness, if there's another system that emerges that's an improvement on this, well, that may become more widely adopted. Cost is a consideration, right? When you buy a CRW frame, that lasts you 5, 10, 15 years. But I understand more recently that CRW frames no longer going to be supported. And in fact, because of that, there's a push in our system to use more of ClearPoint because of my experience with it. Right. So I can't tell you what the field sentiments are because I haven't surveyed it, but I do think that there are many reasons to expect increased insistence on accuracy of biopsy, and more insistence on the outcomes after in the research context.
Sure. A couple more questions in our last few minutes here. My center has optical navigation and a robot. Why would I use ClearPoint for biopsies or laser ablation procedures?
Do you see where your lesion, where your biopsy is with a robot? I mean, the robot doesn't allow you to see inside the brain. Do you avoid skiving 100% just because you used a robot? I mean, those are the questions you have to ask yourself. So if you want to see the lesion, you got to be in an MRI. None of us have Superman X-ray vision. I think it's dangerous to assume that just because you have a robot that you're 100% accurate.
Okay, great. A couple more questions. Given the advantages you mentioned, Dr. Chen, why don't you think adoption has been faster among your peers?
I think the reality, as I said, is if you have a 3 centimeter, 2 centimeter lesion, you don't need this level of accuracy. And that's where most biopsies are being performed. When you have a dedicated oncology practice, though, you do see these really small lesions emerge. And I believe the onus is upon the dedicated surgeon to intervene sooner rather than later. So I would say if I don't use the ClearPoint for every biopsy. If the lesion is 2.5, 3 centimeters, I mean, I don't need to be that accurate. If I need to biopsy a small area within that region, then I would use it. If the lesion is very in close proximity to vasculature or in an area that I'm concerned about, I would use it. I can't comment as to why other people don't, but these are the reasons why I do.
Okay, great. And one last question in our last minute. This comes from Toronto. Outside the trajectory view capabilities that you showed in your slideshow, are there any other software tools or functionality that are particularly useful for tumor biopsy or treatment?
Well, that's at this point, that question is theoretic because we have all sorts of really amazing imaging that we could use, and they're evolving on a daily basis, I mean, rapidly. The problem really is we don't know what these MRI means. We assume we know what they mean, but we have never ever proven it. And so the answer to the question is there's going to be a lot more we can do if we understand what the MRI shows. But we can't understand what the MRI is showing until we actually have a piece of the tissue that is directly in the center of that abnormality. So I think that with time, and maybe by the end of my career, we'll have a better sense of what these things mean. And I think by having that fundamental understanding, we could better develop therapy and interventions. So I think that if you were to take the long view of what this system allow you to do and what the surgeons have to do, I think, again, accuracy of biopsy and confirming that you're analyzing the region of interest is going to be a fundamental premise for how we are going to advance our field in neuro-oncology.
Very good. I want to thank you for your time, Dr. Chen. It's been a wonderful presentation. Thank you for your patience in answering all our questions. And if there are further questions, I hope if you wouldn't mind if we would be able to forward those to you from the audience.
Not at all. Not at all.
Great.
Thank you.
And then just a shout out to our next ClearPoint TV webinar in 2021 on January 27th at 10 a.m. Dr. Willie, who has recently relocated from Emory to Washington University, will be speaking about use of ClearPoint to target the thalamus and guide DBS and RNS treatments for epilepsy. So that registration will go out in our follow-up email. So I want to thank you very much again, Dr. Chen. Have a wonderful day, and thank you everyone for joining.